Welcome to Evidence of the Bedside Board Review Edition. We are so thrilled to have you joining us for today's deep dive.
Yeah, thanks for tuning in, everyone.
We're jumping right into a topic that is just absolutely central to your clinical practice on the wards. And crucially, it is so central to your success on the ABIM certification exam.
Oh, absolutely.
We're talking about diagnostic testing in cardiology.
Which is, it's the perfect place to start. We are going to be thoroughly examining the highly nuanced world of cardiac stress testing,
Right.
non-invasive imaging, and those diagnostic algorithms that dictate modern cardiovascular care. Because this isn't just a passing topic on the boards.
Not at all.
Cardiology diagnostic testing makes up a massive, highly testable chunk of the exam. The boards are heavily focused on this because, well, it tests your clinical judgment in real-time, high-stakes scenarios.
Yeah, it's not just about knowing what a specific nuclear scan does in a vacuum, right?
Exactly. It is about choosing the exact specific right test for a highly detailed patient scenario, while simultaneously avoiding the testing traps that the exam writers have just carefully laid out for you.
And we know that as you are preparing for this exam, you're likely feeling completely overwhelmed by the sheer volume of guidelines. All the flowcharts and algorithms.
There are so many.
Too many. Our mission today is to cut through all of that noise. We want to give you the clinical shortcuts to being truly well-informed, extracting the most important high-yield nuggets of knowledge from the clinical guidelines.
So you can walk into that exam room or even step up to the podium during morning report with absolute confidence.
Right. And if you find this deep dive helpful for your studying, we'd really love for you to subscribe to the show. And please share it with your fellow residents and colleagues who are also in the trenches preparing for their boards.
So to really get into the minds of the test writers, we have to establish why this specific topic is tested so relentlessly. What you have to understand is the underlying philosophy of the ABIM exam. The boards are fundamentally trying to evaluate your ability to determine the next best step in management.
The classic next best step.
They do not just want to know if you can identify the classic textbook signs of ischemia. They want to know if you can balance a patient's pretest probability, their physical limitations, and their baseline ECG abnormalities to safely, accurately, and cost-effectively arrive at a diagnosis.
I want to break down this next best step concept because anyone who has done practice questions knows it is the holy grail of board prompts.
Oh, yeah.
You're sitting at the computer terminal, the clock is ticking, and the prompt reads something like a 64-year-old man presents to the clinic with a 3-month history of exertional chest pain. And then you get a dense paragraph of vital signs and lab values.
And past medical history.
Right. So what are the exam writers actually trying to extract from you in that moment?
They are looking for your ability to act as a clinical gatekeeper. In that scenario, with the 64-year-old man experiencing exertional chest pain, they are going to give you 5 testing options at the bottom of the screen that all sound incredibly plausible.
They always do.
Right. They might offer a standard exercise ECG, a dobutamine stress echo, a coronary CT angiogram, a vasodilator and nuclear perfusion scan, or going straight to invasive coronary angiography.
Right.
Your job is to sift through the clinical clues embedded in that dense paragraph to definitively rule out 4 of those options. You are protecting the patient from the wrong test.
How do you practically do that when you are under time pressure, though? Are there specific anchors you should be looking for in the vignette?
Absolutely. The test writers will always give you exactly what you need to make the decision. Nothing is truly hidden if you know where to look. You need to ask yourself 3 critical sequential questions as you read the prompt.
Okay, what's the first one?
First, what is the patient's resting baseline ECG doing? Second, can this patient physically exercise on a treadmill? And third, do they have specific active comorbidities, like severe bronchospastic asthma or end-stage renal disease?
So those clues are not just clinical filler to make the story sound realistic.
Not at all. They are the literal keys that instantly rule out certain testing modalities.
That makes a lot of sense. The boards are trying to mirror the clinical reality of the wards. Because if you order the wrong test in actual practice, you aren't just losing points on a test.
Right. You are exposing the patient to unnecessary radiation or potential contrast-induced nephropathy.
Or incredibly dangerous pharmacological side effects.
You've hit on the exact mechanism of why this matters. The boards want to see that you can navigate those real-world risks. They want to ensure you aren't going to send a patient into anaphylaxis or acute renal failure just to get an image you didn't even need in the first place.
Since we were talking about making the right choice, I want to back up to the most fundamental decision tree in this whole process, Pretest probability.
Yeah.
The sources highlight that cardiac stress testing is most effective and truly only indicated for patients with an intermediate pretest probability. We are generally talking about a likelihood of disease ranging from 10% to 90%, though some newer guidelines narrow that even further.
Right.
Why is this intermediate zone the absolute sweet spot for testing?
This comes down to the fundamental principles of Bayes' theorem. Now, the boards don't expect you to calculate complex probabilities using a scratch pad, but they do expect you to apply the concept intuitively.
Give us an example.
Let's look at the extremes. If you test a patient with a very low likelihood of disease, say a 25-year-old with sharp, fleeting, atypical chest pain that gets worse when they take a deep breath or press on their ribs, a positive test result in that patient is almost certainly a false positive. Statistically, it is incredibly unlikely they have obstructive coronary artery disease.
But a false positive isn't just an annoyance, right? It sets off a whole chain reaction.
Exactly. We call it the cascade of downstream testing. That healthy 25-year-old gets a false positive stress test. Now the clinician feels obligated to act on it. The patient experiences immense anxiety. They get referred to a cardiologist, and they might even end up getting an invasive procedure like a left heart catheterization.
Wow.
And that procedure carries real tangible risks of access site bleeding, coronary dissection, or atherosclerotic events. You have actively harmed a healthy person by ordering a test they never needed.
Okay, so that is the danger of testing the low-risk patient. What about the other extreme, the high-risk patient?
On the flip side, imagine you have a high-risk patient. Let's say it is a 75-year-old patient with typical crushing substernal angina that radiates to the jaw, heavily provoked by walking up a single flight of stairs.
Classic.
And who also has a history of type 2 diabetes and a prior myocardial infarction. The pretest probability that this patient has obstructive coronary disease is extraordinarily high. If you put them on a treadmill and the test comes back negative, what are you going to do? Are you going to tell them their heart is fine and send them home?
I certainly hope not. You'd assume the test missed something.
Precisely. In a high-risk patient, a negative stress test is highly likely to be a false negative. You cannot trust the negative result because the clinical story is screaming at you that they have disease. Therefore, putting them on a treadmill just delays the inevitable and potentially provokes an acute coronary syndrome during the test itself.
This is the last thing you want.
Right. That high-risk patient should bypass stress testing entirely and go straight to invasive coronary angiography to define the anatomy and potentially intervene.
So that leaves us with the intermediate risk patient.
Right. The intermediate risk patient is where the diagnostic test actually has the power to shift your management. In this group, the test performs exactly as intended. A positive test reliably confirms the presence of disease, allowing you to escalate medical therapy or consider revascularization.
And a negative test.
A negative test reliably rules out the disease, allowing you to reassure the patient and look for non-cardiac causes of their pain. You only order the test if the result will change what you do next.
That is such a clarifying way to look at it. It protects the patient from harm on both ends of the spectrum. Now let's get into the actual mechanics of the stress test itself, specifically the major fork in the road, the choice between exercise stress and pharmacologic stress.
This is huge.
I am looking at the sources, and they are incredibly emphatic about this. The golden rule seems to be always choose exercise if the patient is physically capable. Why the strong preference?
It is arguably the most important rule in non-invasive cardiology. If the patient can walk, they should walk on the treadmill. The reason is that a patient's exercise capacity is a massive independent predictor of outcomes and mortality.
And we measure that in MIT-Ts.
Yes, MEN-Ts or metabolic equivalents of task. 1 MT is defined as the amount of oxygen consumed while sitting at rest. The guidelines and the board exams heavily emphasize that the inability to achieve 5 MTs during a stress test is associated with a significantly higher all-cause mortality, regardless of whether ischemia is actually detected on the ECG or the imaging.
Wait, I want to visualize this. What does 5 ETs actually look like for a patient in the real world?
It is a very functional metric. 5 ETs is roughly the equivalent of walking up a flight or two of stairs at a normal pace without needing to stop and catch your breath, or walking on level ground at a brisk pace of about 4 miles per hour.
Okay.
If a patient gets on the treadmill and has to stop at stage 1 of the Bruce protocol because they are exhausted or severely short of breath, their prognosis is fundamentally different than someone who can sail through stage 3.
So by putting them on the treadmill, you are getting this incredible prognostic data
Yeah.
that you just wouldn't get if they were lying on a table receiving a medication.
Yes, and it goes beyond just the METs. Exercise provides invaluable dynamic physiological data. You get to see their heart rate response to exertion. Do they have chronotropic incompetence where their heart rate just won't rise?
Right.
You get to see their blood pressure augmentation. Does their blood pressure drop during exercise, which is a massive red flag? And crucially, you get to see if their specific clinical symptoms, the exact chest pain they described in the clinic, are actually provoked by physical exertion in a controlled environment.
You are recreating their daily life.
Exactly. You lose all of that rich hemodynamic and symptomatic data when you just inject a vasodilator into an IV.
That makes total sense.
Yeah.
But of course, the board writers are never going to make it that straightforward. They will throw medication complications at you.
Always.
Let's say we have a patient who is perfectly capable of exercising. They can walk 3 miles a day. But they happen to be taking a beta blocker like metoprolol for baseline hypertension. How do we manage their daily medications before sending them to the stress lab?
This is a scenario that trips up residents on the wards constantly, and the ABIM writers exploit it heavily. The answer depends entirely on the clinical goal of the test.
Okay, break that down.
If your primary goal is diagnosing coronary artery disease, meaning we do not know if they have blockages yet, and we are trying to establish a diagnosis, you must withhold beta blockers for at least 24 to 48 hours prior to the test, depending on the specific half-life of the drug.
And what happens if you forget to hold it? Why does it ruin the test?
Think about what beta blockers do. They are negative chronotropes. They blunt the heart rate response. To have a diagnostically adequate and interpretable stress test, the patient must achieve at least 85% of their age-predicted maximal heart rate.
Which is roughly 220 minus the patient's age.
Right. If they're heavily beta-blocked, they might walk on the treadmill until their legs give out, but their heart rate might never get above 100 beats per minute. If they don't hit that 85% target and the test doesn't show ischemia, you haven't actually ruled anything out.
So the test is basically useless.
The test is termed inadequate or non-diagnostic, and you have to do it all over again.
Okay, so for diagnosis, you hold the beta blocker. Is there ever a scenario where you keep them on it?
Yes. If the patient already has known documented coronary artery disease, perhaps they had a stent placed 2 years ago, and you are testing them to evaluate the efficacy of their current anti-anginal medical therapy, or to determine their functional capacity and prognosis, you keep them on their medications.
Oh, interesting.
You actually want to see how their heart performs under the protective umbrella of their daily medical regimen. You are asking, is their current medication dose enough to prevent ischemia when they exert themselves?
That is a brilliant distinction. Diagnosing a new problem versus evaluating an existing treatment plan. Another great pearl from the sources revolves around what they call the warranty period of a stress test.
The warranty period, yes.
Let's say a patient has a completely normal, diagnostically adequate stress test. They hit their target heart rate. The ECG was pristine, no symptoms. A few months later, they come back to the clinics. How long is that negative test reliable?
The universally accepted warranty period for a normal stress test is exactly 1 year. If a patient returns to the clinic, say 8 months after a pristine stress test, and they are complaining of the exact same atypical fleeting chest pain that prompted the initial test, you do not need to repeat the stress test or escalate to a catheterization.
You just rely on the previous one.
You can confidently rely on that negative result for a full 12 months, provided their clinical picture or the character of their pain hasn't acutely and drastically worsened. It gives you the confidence to reassure the patient and explore non-cardiac etiologies like gastroesophageal reflux or musculoskeletal pain.
Let's shift our focus and look under the hood at what is physiologically happening when the heart actually starts to experience ischemia. The sources spend a lot of time detailing something called the ischemic cascade.
This is my favorite part.
It's fascinating. This is the sequential physiological chain of events that occurs when the myocardium's demand for oxygen outstrips the supply provided by the coronary arteries. Why is understanding this cascade so critical for the boards?
Because understanding the ischemic cascade is the absolute key to understanding why we choose different imaging modalities and why some tests are inherently more sensitive than others. It is a beautiful, predictable illustration of cardiac pathophysiology.
Let's walk through it.
Imagine a patient with a 70% narrowing in their left anterior descending artery. At rest, the blood flow is adequate, but now you put them on a treadmill. Their heart rate increases, their blood pressure goes up, and the heart muscle demands vastly more oxygen.
But the narrowed artery can't deliver it.
Right, so the supply-demand mismatch begins. The very first thing that happens in the cascade is a localized relative drop in blood flow to the tissue supplied by that narrowed artery compared to the healthy arteries.
So a perfusion defect.
Exactly. This is a perfusion defect. It happens at the microvascular capillary level incredibly early in the process.
Okay, so blood flow drops. What happens to the heart muscle cells next?
If the ischemia persists, the next thing to fail is actually diastolic relaxation. The affected segment of the heart muscle becomes stiff.
Wait, I'm trying to picture this. The muscle gets stiff before it stops squeezing. That feels totally backwards. You'd think a starving muscle would just get weak and stop contracting first.
It is a massive conceptual hurdle, but it makes perfect sense when you look at the cellular machinery. Relaxation of the cardiac myocyte is an active process that requires a tremendous amount of energy in the form of ATP.
Okay.
To relax the muscle, calcium has to be actively pumped out of the cell's cytosol and back into the sarcoplasmic reticulum by the circupumps. Pumping calcium against its concentration gradient requires ATP. When the cell is ischemic and starving for oxygen, ATP production plummets.
So without ATP, the calcium cannot be cleared.
Right. The muscle remains in a state of partial contraction. It literally stiffens up. It is essentially experiencing a cramp, much like your calf muscle might cramp during a long run when it runs out of energy.
That is a fantastic analogy. So it cramps up and gets stiff. This is diastolic dysfunction. Then what?
If the oxygen mismatch continues further, the actin-myosin cross-bridging cycle begins to fail entirely. The affected segment of the myocardium loses its ability to contract forcefully. It stops squeezing properly.
We call this a regional wall motion abnormality.
Yes. You can visibly see this on an ultrasound. One wall of the heart is contracting beautifully, and the ischemic wall is just sitting there sluggish or entirely hypokinetic.
So we have a perfusion drop, then a stiff muscle, then a weak muscle.
Right.
Where does the ECG come in?
It is only after all of these mechanical failures have occurred, the perfusion drop, the diastolic stiffness, the systolic failure that the ion pumps at the cell membrane fail so completely that you finally see electrical changes on the surface electrocardiogram, like the classic ST segment depression.
Now, what about the patient? When do they actually feel the chest pain?
The very last step in the entire cascade, the final manifestation of all this underlying cellular and mechanical chaos, is the patient actually feeling angina. The ischemic cells release metabolites like adenosine and bradykinin, which stimulate local nerve endings, sending a pain signal up to the brain.
That sequence changes how I view everything. Perfusion changes, then diastolic dysfunction, then systolic wall motion abnormalities, then ECG changes, and finally the actual symptom of angina. So when we map our diagnostic tests onto that cascade, it becomes incredibly clear why imaging is so much more sensitive than just looking at a basic ECG tracing.
You've nailed it. If you are relying solely on a standard exercise ECG, you are waiting for the second-to-last step in the ischemic cascade to occur before you can make a diagnosis. The patient has to push themselves deep into ischemia before the electrical signals change.
Which takes time and stress.
By adding imaging to the stress test, like a nuclear perfusion scan, to detect those very early blood flow disparities, or a stress echocardiogram to visibly watch for those regional wall motion abnormalities, you are moving upstream in the cascade. You are catching the tissue starvation much earlier in the process, which drastically improves the overall sensitivity of your test.
I want to break down the actual categories of testing we use to detect this cascade, because the sources divide them into two very distinct philosophical approaches. Functional testing versus anatomic testing. What we've been talking about so far, the flow, drops the wall, motion issues, that is all functional testing, right? We are looking at the physiological consequences of the ischemia.
Correct. Functional testing asks the question, is the heart muscle receiving enough oxygen right now? This category includes your standard exercise ECG, the stress echocardiogram, suspective myocardial perfusion imaging, and advanced modalities like cardiac PT and cardiac MRI.
Let's talk about the nuances within those functional tests, particularly cardiac PT, because the guidelines seem to position it as a superior technology in certain scenarios.
Cardiac PE, or positron emission tomography, provides the absolute highest quality perfusion images we have. It is particularly invaluable for patients with a very high body mass index.
Why is that?
With a standard SPECT nuclear scan, the gamma rays have to travel through the patient's chest wall, breast tissue, and diaphragm to reach the camera. In a patient with obesity, that dense tissue absorbs or scatters the radiation. It's a phenomenon known as soft tissue attenuation artifact.
So it makes a normal heart look abnormal.
Exactly. It can make a perfectly healthy heart look like it has a massive perfusion defect.
So P cuts through that artifact.
Yes. Pete uses different higher energy radio tracers, usually rubidium-82 or nitrogen-13 ammonia, and the coincidence detection of the Pete scanner naturally corrects for that soft tissue attenuation. You get incredibly crisp, artifact-free images. Furthermore, PE allows for the quantitative measurement of absolute myocardial blood flow.
Absolute flow. That's amazing.
We aren't just comparing one wall of the heart to another. We can actually calculate how many milliliters of blood are flowing through every gram of tissue per minute.
That sounds like the ultimate test. Why don't we just use PE for everyone? What's the catch for the board exam?
Cost and availability are the real-world catches, but the critical limitation you must remember for the exam is that cardiac PET is strictly a pharmacologic stress test. There is absolutely no exercise protocol for PT.
Why not? If exercise is so great, why can't we put a treadmill next to the PT scanner?
It comes down to the physics of the radio tracers. The tracers used in PT have extremely short half-lives. Rubidium-82, for instance, has a half-life of just 76 seconds.
Ah, that's fast.
You literally have to inject the tracer while the patient is already positioned inside the scannel to capture the image before the radiation decays away. You cannot have a patient run on a treadmill, hit peak exercise, inject them, and then have them walk over and lie down in a scanner. The tracer would be gone.
So PAT is phenomenal, but you sacrifice all of that prognostic exercise data we discussed earlier.
Right.
That is a brilliant board pearl. Short half-life equals no treadmill. Okay, so that is functional testing. What about anatomic testing? How does the philosophy shift here?
Instead of looking for the downstream physiological effects of tissue starvation, anatomic testing looks directly at the coronary arteries themselves to visualize the actual atherosclerotic blockages. We are looking at the plumbing. The prime non-invasive anatomic test is coronary computed tomography angiography, or CCTA.
And the guidelines seem to be heavily favoring CCTA recently.
They are. CCTA provides incredible, high-resolution, three-dimensional visualization of the coronary vessel lumen and the plaques sitting in the walls. The current guidelines strongly prefer CCTA for symptomatic patients who are under 65 years old and have an intermediate pretest probability.
Why under 65 specifically? We'll get to the calcium in a second, I'm sure, but what's its greatest strength?
Its greatest strength is its extraordinarily high negative predictive value. If a high-quality CCTA shows pristine, widely patent coronary arteries, you can be nearly 100% certain that the patient's chest pain is not due to obstructive coronary disease. You can send them home with immense confidence.
But just like Pete, there have to be caveats. What does a patient need to have a successful CCTA?
The heart is a rapidly moving target. Taking a CT scan of a beating heart is like trying to take a clear photograph of a race car speeding by. To get crisp images without motion artifact, the patient needs a slow, steady, regular heart rate. We typically want the heart rate below 60 beats per minute.
So you have to slow them down.
This almost always requires administering oral or intravenous beta blockers in the scanner suite right before the test. The patient also needs to be able to hold their breath perfectly for several seconds. And critically, you need a high-resolution machine, at minimum a 64-slice CT scanner, to capture the whole heart in a single breath hold.
Are there patient populations where CCTA is the wrong choice? What about older patients?
Age is a major factor because of calcium. As atherosclerosis progresses over decades, the plaques often become heavily calcified. On a CT scan, calcium is incredibly dense. It looks bright white, just like bone. If a patient has extensive heavy calcification in their coronary arteries, that bright white signal blooms or scatters on the image, completely obscuring the dark lumen inside.
It creates a glare.
Exactly. When the vessel is obscured by this calcium blooming artifact, the radiologist cannot accurately quantify whether the actual narrowing is 20% or 90%. The scan becomes non-diagnostic. Therefore, in older patients who are highly likely to have heavily calcified arteries, CCTA is often a poor choice.
And speaking of calcium, we have to address a point of major confusion. We need to talk about coronary artery calcium scoring, or the Sieve score. This is a topic that trips up a staggering number of test takers because the acronyms are so similar to CCTA.
It is a critical distinction that the boards will absolutely test you on. A CAG score is entirely different from a CCTA. A CAG scan is a very quick, non-contrast CT scan of the chest. It does not use intravenous contrast dye. Its sole purpose is risk stratification in completely asymptomatic patients who are at intermediate clinical risk for future cardiovascular events. It quantifies the total burden of calcified plaque in the epicardial coronary arteries and gives you a number, the Agatston score.
What do the numbers actually mean?
A score of absolute 0 is a very powerful negative risk marker. It means there is no detectable calcified plaque, and the risk of a heart attack in the next decade is exceptionally low. We often use a score of 0 to justify holding off on statin therapy in patients who are on the fence.
And a high score.
On the other hand, a score over 400 indicates a severe extensive burden of atherosclerotic disease, placing them in a high-risk category, warranting aggressive lipid-lowering therapy and perhaps aspirin.
But what is the major limitation? What can't it do?
Here is the keyboard fact. A non-contrast CAC score does not show you the vessel lumen. It does not show soft non-calcified plaques, which are often the ones that rupture and cause heart attacks. Most importantly, it tells you there is calcium in the wall, but it gives you zero information about whether that plaque is causing a 10% narrowing or a 99% critical stenosis.
So if a patient comes into the emergency department actively clutching their chest, sweating, and complaining of crushing angina,
You never, ever order a CAC score. It cannot diagnose the cause of acute chest pain. The boards will offer it as an option for a symptomatic patient just to see if you understand that it is purely a primary prevention tool for asymptomatic individuals. Do not fall for it.
Excellent. Okay, rounding out our core concepts before we get to the clinical vignettes, let's briefly touch on structural and arrhythmia testing basics. When we're looking for structural heart disease, valvular issues, ejection fraction, to transthoracic echocardiogram, the standard TTE is our everyday workhorse. It's cheap, fast, and uses zero radiation. But when do we need to escalate to the invasive transesophageal echocardiogram, the T?
The T involves passing an ultrasound probe attached to an endoscope down the patient's esophagus, positioning it directly behind the left atrium of the heart. The standard TTE has to shoot sound waves through the ribs, muscle, and lungs, which often degrades the image quality.
Right, it's a long way for the sound to travel.
Exactly. The esophagus is right up against the heart, so the T gives you unparalleled high-resolution views of the posterior cardiac structures. The boards will expect you to choose T in very specific high-stakes scenarios.
What are those classic board scenarios?
First, assessing for infective endocarditis, particularly if you suspect an aortic root abscess or if the standard TTE was negative, but your clinical suspicion remains extremely high.
Okay, what's the second?
Second, evaluating a patient with a prosthetic heart valve. The metal struts of a mechanical valve create dense acoustic shadowing that completely obscures the areas behind it on a standard surface echo. The T looks from behind by passing that shadow.
And the third scenario?
And third, ruling out a left atrial appendage thrombus before performing a synchronized cardioversion in a patient with atrial fibrillation. You must prove there is no clot hiding in that appendage before you shock the heart back into a normal rhythm. Otherwise, you could dislodge it and cause a massive stroke.
Perfect. And for arrhythmias, the rules for outpatient monitoring seem very intuitive. It's all about matching the specific monitor to the frequency of the patient's symptoms.
Exactly. It's a simple matching game. If the patient tells you, I feel my heart racing and skipping beats every single day after lunch, you order a continuous 24 to 48-hour Holter monitor. You are almost guaranteed to capture the event in that time frame.
What if the symptoms are more sporadic?
If they say it happens maybe once every 2 or 3 weeks, a Holter is useless. You give them an event recorder. This is a device they wear for up to 30 days. It constantly records a loop of their rhythm, but it only saves the data when the patient physically presses a button during their symptoms, or if the device algorithm detects a dangerous auto-triggered event like ventricular tachycardia.
And what about the most extreme case? The patient who says, I have no warning, I just completely black out and wake up on the floor, but it only happens maybe once or twice a year. A 30-day monitor is likely going to miss that entirely.
For very rare, potentially life-threatening events, especially unexplained syncope where you strongly suspect a dangerous intermittent arrhythmia, the answer is an implantable loop recorder, or ILR. It is a tiny device about the size of a flash drive or a large paperclip that is injected subcutaneously under the skin of the chest.
How long does that last?
Its battery can last for up to 3 or 4 years. It continuously monitors the heart day and night, waiting patiently to capture that rare, fleeting, catastrophic electrical event.
Okay, this is where it gets really interesting. We are going to put all of these dense physiological concepts to the test. We have designed 3 board-style clinical vignettes based directly on the source material. We are going to walk through the scenario, identify the correct diagnosis or next best step, and most importantly, we're going to dissect exactly why the alternative options are dead wrong.
I am ready when you are. Let's analyze the first scenario.
Vignette 1. We call this the LBBB trap. You have a 68-year-old patient who presents to your outpatient clinic complaining of exertional chest pain that forces them to stop their daily activities. You get a baseline resting 12-lead ECG, and it shows a classic left bundle branch block and LBBB. You take a further history, and the patient reveals they have severe bone-on-bone osteoarthritis in both knees and cannot walk on a treadmill for more than a few seconds without excruciating joint pain. What is the next best step in their management?
This is a masterclass in how the boards design questions to test multiple layers of knowledge simultaneously. The test raters have handed you two critical non-negotiable pieces of information. First, the baseline ECG is abnormal with an LBBB. Second, the patient is physically incapable of exercising. Let's logically break down the options. Could we do a standard exercise ECG on the treadmill?
Well, no. First, physically, they can't walk because of the knees. But even if we magically cure their osteoarthritis today, we still couldn't use a standard ECG, right? Doesn't the baseline RBBB make the tracing completely uninterpretable for ischemia?
You've hit the nail on the head. The repolarization abnormalities that are inherently present in a left bundle branch block, the wide QRS, the discordant ST segments and T waves, will completely mask or falsely mimic the classic ischemic ST changes we look for during stress. So standard exercise ECG is entirely off the table. We need imaging to look at the heart muscle itself. And because they cannot exercise, we are forced into the realm of pharmacologic stress testing.
Okay, so we need a drug and an imaging camera. The main choices for pharmacologic stress are dobutamine or a vasodilator like adenosine dipyridamole or regotinols. I know a lot of people on the wards might suggest a dobutamine stress echocardiogram here. Dobutamine is an inotrope and a chronotrope. It makes the heart beat faster and harder, beautifully simulating the physiological stress of exercise without the patient moving a muscle. Why is that the wrong answer?
And that is the exact trap the boards want you to fall into. Dobutamine is the absolute wrong answer here, and the underlying physiological reason is fascinating. It comes down to the actual mechanical sequence of how a left bundle branch block alters the contraction of the heart.
Let's walk through that. What is actually happening in an LBBB?
In a normal, healthy heart, the electrical signal travels rapidly down both the right and left bundle branches, simultaneously causing the ventricular septum and the free walls to contract, synchronously squeezing the blood out. But in an LBBB, the left bundle is blocked. The electrical signal travels normally down the right side, but to get to the left ventricle, it has to slowly plod its way cell by cell across the myocardium.
So the electrical wiring is delayed. What does that do to the pumping mechanics?
It causes dysynchrony. The right ventricle and the septum start to contract before the main free wall of the left ventricle. Because of this abnormal timing, the septum often moves paradoxically. It briefly bulges the wrong way during the cardiac cycle. Now, at a resting heart rate, this isn't a huge issue for blood flow, but when you artificially drive the heart rate up significantly, either through actual physical exercise or by infusing a stimulant like dobutamine, this asynchronous paradoxical septal motion becomes very pronounced and violent.
And how does that affect the imaging scan?
This is the crux of the trap. On a nuclear perfusion, scan this abnormal mechanical squeezing and wringing of the septal tissue at high heart rates actually physically limits the blood flow into the septal capillary bed during systole. It creates a localized drop in blood flow. So the nuclear camera takes a picture and sees a massive perfusion defect in the septum.
Wow.
It looks exactly like severe ischemia or a blockage in the left anterior descending artery, but it's an artifact. It's just a mechanical consequence of the conduction block at high heart rates.
So if you choose exercise or dobutamine in a patient with an LBBB, you will likely see a defect in the septum. You will declare the test positive, you will send that patient to the cath lab for an invasive angiogram, and the interventionalist will find that their arteries are completely clean. You fell for the trap, and the patient underwent an unnecessary procedure.
Exactly. Therefore, to avoid this false positive, you must stress the heart without significantly raising the heart rate. The only correct answer in this scenario is vasodilator myocardial perfusion imaging. Vasodilators like adenosine or oreganosin work by directly dilating the coronary capillary beds. They create a massive flow disparity between the healthy, fully dilated vessels and the diseased vessels that can't dilate any further. But crucially, they do not significantly increase the resting heart rate.
That's the key.
Because the heart rate stays relatively low, you do not provoke that severe asynchronous septal motion, and you completely avoid the false positive artifact. If you see LBBB on the boards, immediately look for the vasodilator option.
Brilliant breakdown. Let's move to Vignette 2, which presents a completely different challenge. We'll call this the asthma conundrum. You are evaluating a 50-year-old patient in the emergency department who needs a stress test to work up new onset chest tightness. However, they recently suffered a severe compound foot fracture and are in a non-weight-bearing cast. They cannot exercise. During your physical exam, you note that the patient has a history of severe active asthma, and as you're listening to their lungs with your stethoscope, you actively hear expiratory wheezing. What is the next best step?
Once again, we apply our rigid algorithmic thinking. Can they physically exercise? No, the cast prevents it. So we are once again in the realm of pharmacologic stress testing. We just established in the last vignette that vasodilators and dobutamine are our two primary options for drugs. In the LBBB vignette, we loved vasodilators, but in this asthmatic patient, they are strictly, unequivocally contraindicated.
Why? What is the danger of giving adenosine or dipyridamole to this patient?
It has everything to do with cellular receptors. These vasodilator agents work primarily by agonizing the adenosine A2A receptors in the coronary vasculature, which causes profound vasodilation. That is the intended effect. However, the pharmacology isn't perfectly selective. There are also adenosine A2B and A3 receptors heavily populated throughout the pulmonary bronchial tree.
And what happens when those pulmonary receptors get stimulated?
Agonizing those receptors in the lungs provokes severe immediate bronchospasm and mast cell degranulation. In a healthy person, it might cause a mild cough or a fleeting feeling of breathlessness. But in a patient with active hyperreactive airway disease who is already wheezing, administering a vasodilator could trigger a massive life-threatening status asthmaticus attack right there in the stress lab. You could precipitate respiratory failure.
That is terrifying. So vasodilators are completely out. What is the correct answer?
The correct answer is to pivot to the inotrope. You order a dobutamine stress echocardiogram or a dobutamine myocardial perfusion scan. Dobutamine is primarily a synthetic beta-1 adrenergic agonist. It directly stimulates the beta-1 receptors on the heart muscle to increase the heart rate and the force of contractility, massively increasing myocardial oxygen demand to provoke ischemia.
But is it safe for the lungs?
Yes. It does not act on the adenosine receptors at all, so it avoids that specific mechanism of bronchospasm. In fact, dobutamine has mild crossover affinity for beta-2 receptors, which are the receptors targeted by albuterol inhalers. So its mild beta-2 agonism might actually provide a tiny bit of bronchodilation. For the asthmatic patient who cannot walk, dobutamine is unequivocally your best friend.
Excellent physiological reasoning. Now for vignette 3, which is a bit of a curveball compared to the standard coronary disease workup, but it is incredibly high yield for the modern ABIM exam as diagnostics have evolved. We call this the HFpEF mystery. An elderly patient presents with progressive debilitating symptoms of heart failure, severe dyspnea on exertion orthopnea, and massive lower extremity edema. You order a standard transthoracic echocardiogram. The echo shows a normal preserved ejection fraction of 60%, but it reveals severe concentric left ventricular hypertrophy. The walls of the heart are massively thickened and have a bright sparkling appearance. Your clinical suspicion is very high for an infiltrative cardiomyopathy, specifically cardiac amyloidosis. You do your due diligence and check their serum and urine for monoclonal proteins to rule out the AL variant of amyloidosis, and those results come back completely negative. What is the next best step to secure the diagnosis?
This specific scenario is appearing more and more frequently on the boards because our diagnostic capabilities for this disease have undergone a revolution in recent years. Let's set the stage. Cardiac amyloidosis is an infiltrative disease where misfolded abnormal proteins deposit into the extracellular space of the myocardium. This rigid protein causes the heart muscle to become incredibly thick and stiff, severely impairing its ability to relax and fill with blood. This leads to classic heart failure with preserved ejection fraction, or HFpEF.
And there are two main types to worry about, right?
Exactly. There is AL amyloidosis, which is essentially a hematologic malignancy driven by a plasma cell dyscrasia producing abnormal light chains. It is rapidly fatal if not treated with chemotherapy. And then there is ATTR amyloidosis, which is caused by misfolded transthyretin proteins that transport proteins synthesized by the liver.
The vignette explicitly tells us that the serum and urine monoclonal protein screens are negative.
Right. By giving you that piece of data, the board writers are telling you that you have effectively ruled out the AL type. The patient does not have the plasma cell dyscrasia. Therefore, you strongly suspect ATTR amyloidosis, which is much more common in the elderly population. In the old days, the absolute only way to prove this diagnosis was to send the patient to the cath lab for an invasive right ventricular endomyocardial biopsy. Literally snipping a piece of the heart muscle with the jaws on the end of a catheter and looking at it under a microscope with Congo red stain.
But the guidelines have changed. Biopsy is no longer the automatic next best step.
It is not. The correct next step is to order a highly specific nuclear imaging test. 99-meter technetium pyrophosphate scintigraphy, almost always abbreviated as a PYP scan or a technetium PYP scan.
Technetium pyrophosphate. Isn't that an old radio tracer we used to use for bone scans to look at metastases? Why are we using it for the heart?
That is what makes this so fascinating. Researchers discovered that this specific bone-avid radio tracer binds aggressively to the microscopic calcium, deposits the microcalcifications that are uniquely associated with ATTR amyloid fibrils in the heart. It does not bind to AL amyloid, and it does not bind to a normal heart.
And how accurate is this scan? Can we really trust it over a physical tissue biopsy?
The statistical power of this test is incredible. If you have a patient with clinical heart failure and echo showing a severely thickened heart, and you have definitively confirmed they do not have a monoclonal protein in their blood or urine, a strongly positive technetium PYP scan that shows intense tracer uptake in the heart has a greater than 99% specificity for ATTR cardiac amyloidosis. It is virtually diagnostic.
That is a game changer for the patient.
Exactly. It completely prevents the need for an immediate, invasive, potentially risky biopsy. The boards want to see that you are aware of this modern, non-invasive diagnostic pathway. If you see an elderly patient with severe LVH heart failure and negative monoclonals, you must bypass the biopsy and look for the technetium pyrophosphate scan as the right answer.
Those vignettes are absolute gold for board prep. Moving along, let's consolidate some rapid-fire facts. These are the high-yield, testable points that you just have to commit to memory. Here's something the boards love to ask. We've talked extensively about when you can use a standard exercise ECG on a treadmill, but you need to have the absolute exclusions memorized cold. You absolutely cannot use a standard exercise ECG to look for ischemia if the resting baseline ECG shows certain specific abnormalities. We already spent a lot of time on the left bundle branch block. What are the other non-negotiable exclusions?
You must abandon the standard exercise ECG and step up to imaging if the baseline tracing shows any of the following. First, a paced rhythm from a permanent ventricular pacemaker. The pacemaker stimulates the right ventricle first, which creates an electrical sequence that perfectly mimics a left bundle branch block, rendering the ST segments uninterpretable.
Okay, what's next?
Second, any evidence of ventricular pre-excitation, such as the classic delta wave seen in Wolff-Parkinson-White syndrome. The accessory pathway distorts the initial part of the QRS and completely ruins the ST segment analysis. Third, severe left ventricular hypertrophy with baseline repolarization abnormalities, often called a strain pattern, because the ST segments are already depressed and asymmetrical at rest. And finally, if there is already greater than 1 millimeter of resting ST segment depression for any reason.
Why does resting ST depression matter if we're looking for more depression during exercise? Can't we just look for a change?
It becomes a mathematical and physiological mess. If they are already depressed at rest, the specificity of any further depression during stress plummets. You cannot reliably discern what is old, what is baseline artifact, and what is true new ischemia. In all of these scenarios, the baseline electrical chaos distorts the tracing, and you must add imaging like a nuclear scan or an echo to actually look at the muscle perfusion or function.
Let's assume the baseline ECG is perfectly normal. It's pristine. The patient gets on the treadmill, they're walking, the incline goes up, and we are intently watching the monitor. What exactly constitutes true diagnostic ischemia on an exercise ECG? The boards love to test the strict millimeter-specific definition.
You're looking closely at the ST segment. Diagnostic ischemia is defined as horizontal or downsloping ST segment depression of at least 1 millimeter, and you must measure it exactly 80 milliseconds after the J point.
I want to clarify that for the listeners. What exactly is the J point, and why does the angle of the slope matter?
The J point, or junction point, is the exact anatomical moment on the ECG where the QRS complex, the rapid polarization of the ventricles, ends, and the ST segment, the plateau phase of repolarization, begins. It is the corner where the fast spike turns into the flat line. You find that corner, you move 80 milliseconds to the right, and you measure the depth. If that point is depressed by 1 millimeter or more compared to the baseline, and the segment is running flat horizontally or sloping downwards, that is ischemia. Downsloping is actually considered much more specific for severe disease than upsloping depression, which can sometimes be a normal variant at very high heart rates.
But here's the crucial board fact that trips up so many people, especially those who work primarily in the ED. If you see that classic 2 millimeter downsloping ST depression occurring in leads V3, V4, and V5 during the stress test, Does that mean the ischemia is localized strictly to the anterior wall supplied by the left anterior descending artery?
No, it absolutely does not. And this is a major conceptual hurdle to overcome. ST segment depression on an exercise ECG does not localize the specific vascular distribution of the ischemia.
Why not? If I see ST elevation in the inferior leads during a STEMI, I know exactly which artery is blocked. Why is depression different?
It comes down to vector physics. An acute ST elevation myocardial infarction, a STEMI, involves transmural injury. The entire thickness of the heart wall is dying. The electrical vector of that massive injury points directly outward toward the overlying ECG lead, so it localizes beautifully. Inferior leads point to the right coronary artery.
Okay, so elevation points outward.
Exactly. But exercise-induced ischemia is typically subendocardial. It affects the inner lining of the heart globally. The electrical vectors of subendocardial ischemia generally point diffusely inward toward the ventricular cavity, not toward any specific surface lead. It just tells you the heart is starving for oxygen somewhere. If you need to know exactly which anatomical region of the heart is ischemic, you must use imaging like a perfusion scan or an echo to see the specific wall failing.
That is a phenomenal explanation. Transmural outward vectors versus subendocardial inward vectors. Let's shift gears and talk more about our pharmacologic agents, specifically dobutamine. We established we love it for our asthmatic patients who can't walk. But when is dobutamine strictly contraindicated? When will choosing it kill the patient in the vignette?
Dobutamine is a powerful aggressive stimulant. You are whipping the heart to run a marathon while the patient is lying perfectly still. You should never choose it for patients who have severe, uncontrolled baseline hypertension, like a resting blood pressure of 200/110, because you will drive it even higher. You never use it in patients with unstable angina who are actively having chest pain at rest, because you will just exacerbate the infarction. It is also contraindicated in patients with severe tachyarrhythmias, like uncontrolled atrial fibrillation, because you will just drive the ventricular rate dangerously fast.
What about structural problems? The mechanical contraindications seem incredibly testable.
They are the most testable. You must absolutely avoid dobutamine in patients with hypertrophic cardiomyopathy, with severe outflow tract obstruction, severe critical aortic stenosis, or a large unstable aortic aneurysm.
Let's explain the physics of why. If a patient has severe critical aortic stenosis, their aortic valve is narrowed down to a tiny, heavily calcified pinhole. If you hit that heart with a massive intravenous dose of dobutamine, forcing the left ventricle to contract with extreme maximal force against a fixed, impenetrable, rock-hard obstruction, what happens hemodynamically?
You create a catastrophic hemodynamic crisis. The pressure inside the left ventricle skyrockets as it tries to push blood through the pinhole. But because the blood can't get out, the forward cardiac output plummets. When cardiac output drops, the systemic blood pressure drops, which means the coronary perfusion pressure plummets. The hypertrophied heart muscle, which is now working harder than ever, is suddenly starved of blood. The patient can rapidly develop severe ischemia, lethal ventricular arrhythmias, or complete cardiovascular collapse and syncope. It is a disaster.
And I imagine the mechanism for a large aortic aneurysm is similarly destructive.
Exactly. With a large aortic aneurysm, the wall of the aorta is thin, weak, and stretched to its limit. The sudden violent spike in myocardial contractility caused by dobutamine creates massive shear stress and a huge pressure wave that slams into that weakened aortic wall. You could easily provoke an acute aortic dissection or a fatal rupture right there on the table. Always respect the mechanical and structural limits of the heart before using a powerful inotrope.
Let's round out this high-yield segment with a critical warning about cardiac MRI. CMR is an amazing, rapidly evolving tool. It gives us beautiful tissue characterization, allowing us to see scar tissue fibrosis and infiltration using gadolinium-based contrast agents. But the boards will invariably present a patient who desperately needs a CMR, but has a very specific, dangerous comorbidity. What is the setup?
The test writers will present a patient with severe end-stage kidney disease, specifically someone with an estimated glomerular filtration rate, an eGFR of less than 30. In these patients, the intravenous use of group I gadolinium-based contrast agents is strictly, absolutely contraindicated.
And the reason isn't just the typical contrast-induced nephropathy we see with the iodine-based dye used in CT scans, right? What specifically happens with gadolinium when the kidneys fail?
It is a much more sinister process. Gadolinium is a heavy metal. To make it safe for injection, it is tightly wrapped inside a chemical cage called a chelate. Normally, healthy kidneys filter out the chelate within a few hours, but if a patient has an eGFR less than 30, the chelate stays in the bloodstream for days. Because it sits there so long, the bond breaks down and the highly toxic free gadolinium ion dissociates from the cage and deposits directly into the patient's tissues.
And what disease does that trigger?
It triggers a devastating untreatable condition called nephrogenic systemic fibrosis, or NSF. The free gadolinium causes a massive inflammatory reaction that leads to severe, painful, woody thickening and hardening of the skin, the joints, and eventually the internal organs. Patients can become completely wheelchair-bound from contractures, and it can be fatal. There is no cure. It is a classic high-yield board association, you must know. eGFR less than 30 plus gadolinium contrast equals nephrogenic systemic fibrosis. Just do not order it.
Okay, we are moving into the clinical pearls and pitfalls section of our deep dive. These are the subtle clinical traps and real-world scenarios that differentiate an average test taker from a truly great clinician. Let's start with what we'll call the theophalling pitfall. We discussed earlier that vasodilators like regadenosin and adenosine work by agonizing the A2A receptors in the heart. What if the patient is taking a daily medication or consumed a beverage that directly interacts with those very same receptors?
This is a fantastic pearl that touches on pharmacology and clinical history taking. If a patient is taking theophylline as a daily maintenance inhaler or pill for severe COPD, or even if they just consumed a massive amount of heavy caffeine, like drinking a large quadruple espresso or 2 energy drinks in the waiting room before the test, vasodilator stress tests will not work properly.
Why not? What are the theophylline and caffeine doing at the cellular level?
Theophylline and caffeine are both potent competitive antagonists at the adenosine receptor. They literally bind to the receptor and block it, acting like a key broken off in a lock. So if the patient has these substances in their blood and you infuse your expensive dose of adenosine or regadenosin, the drug molecules have nowhere to bind. The receptors are already occupied, the coronary arteries will not dilate, you won't create the flow disparity, and you will get a falsely normal, completely uninterpretable test result, potentially missing severe life-threatening coronary disease.
So the management step is clear. You must take a good history. Theophylline medications and all caffeine must be strictly withheld for 12 to 24 hours before a vasodilator stress test. But the pharmacological corollary to this is also a great board question. Let's say you do the test perfectly. The patient held their caffeine, you infuse the adenosine, and it works beautifully. But suddenly, the patient starts experiencing severe, terrifying side effects, crushing chest pain, intense facial flushing, a terrible throbbing headache, or profound hypotension. You need to stop it immediately. How do you rapidly reverse those symptoms?
You use the knowledge of that pitfall as your cure. Because we know theophylline and caffeine block the receptor, you can actually administer an intravenous dose of aminophylline or theophylline after the test to immediately antagonize the receptors. It rapidly kicks the adenosine off the receptors and instantly reverses those severe adverse effects. It's a brilliant, highly effective pharmacological antidote.
I love that. Our next pearl revolves around a concept called heart rate recovery. We mentioned at the very beginning that a patient's exercise capacity, their MTs, is a great prognostic indicator. But what happens after the treadmill stops is just as important, isn't it?
Yes, the recovery phase is deeply revealing about the health of a patient's autonomic nervous system. Normally, when you are running, your sympathetic nervous system is driving your heart rate up. The moment you stop exercising your parasympathetic nervous system specifically, the vagus nerve rapidly re-engages to put the brakes on and slow the heart rate back down to resting levels. A healthy, robust heart rate drops very quickly the moment exertion stops.
But what if it doesn't? What are we looking for numerically?
We look at the very first minute of recovery. A drop of less than 12 beats per minute in the first minute after the exercise stops is a massive glaring red flag. We call this a blunted heart rate recovery. It indicates profound autonomic dysfunction, essentially a failure of vagal reactivation. The literature shows that this specific finding is independently associated with significantly higher all-cause mortality over the next several years, even if their coronary arteries are clean. It is a subtle finding on the final report, but a critical one for long-term risk stratification.
For our final pitfall, we are stepping out of the non-invasive stress lab and into the immediate aftermath of the invasive catheterization lab. The boards absolutely love to test your recognition of post-procedural complications. Here is the scenario. The vignette describes a patient who just underwent an invasive coronary angiography with stent placement. The cardiologist used the femoral artery approach in the groin for access. A few hours later, the patient is recovering on the floor and the nerve calls you urgently to the bedside. The patient's blood pressure has suddenly dropped from 120/80 to 85/50. They are tachycardic at 115 beats per minute. They're complaining of severe deep ache in their flank or lower back, and their most recent stat hemoglobin level has dropped by 2 full grams.
What just happened?
You must immediately suspect a retroperitoneal hemorrhage. This is a life-threatening emergency. Here's the anatomy. The femoral artery stick was likely made too high above the level of the inguinal ligament where the vessel transitions into the external iliac artery. When the procedural sheath was eventually removed, the artery failed to seal and began to bleed. But because the artery is positioned deep in the retroperitoneal cavity at that high level, the blood doesn't pool visibly under the skin. It doesn't form a huge, obvious hematoma on the front of the thigh.
So where does the blood go?
It tracks backward, filling up the massive, empty potential space of the retroperitoneum. A patient can literally bleed their entire blood volume out into this hidden space with very few external physical signs. You might eventually see bruising on the flanks known as gray Turner sign, but by then it is very late. The only early signs are the unexplained hypotension, the tachycardia, the sudden drop in hemoglobin, and that telltale referred pain to the flank or lower back as the blood stretches the retroperitoneal tissues.
And the critical next best step question follows immediately. You clinically suspect a retroperitoneal bleed. The patient is crashing. What is the immediate diagnostic test you order to confirm it?
The next best step is a non-contrast CT scan of the abdomen and pelvis. You do not need to waste time or risk kidney injury by ordering intravenous contrast to see a massive pool of fresh, dense blood. The non-con CT will definitively and instantly visualize the hemorrhage.
Once you confirm it, what is the management?
You need to aggressively resuscitate the patient with intravenous fluids and blood products to maintain perfusion and immediately consult interventional radiology or vascular surgery to locate the exact hole and coil or repair it to control the bleeding. You cannot just hold pressure on the groin. The hole is too high and too deep. You must recognize the scenario instantly on the exam.
Okay. We are in the home stretch. It is time for our rapid board review takeaways. We are going to fire off 5 concise, extremely high-yield associations you need to have locked into your short-term memory for exam day.
Takeaway 1. If you see a left bundle branch block or a paced ventricular rhythm on a resting ECG in the prompt, immediately think vasodilator myocardial perfusion imaging. Do not choose an exercise or dobutamine option because you must avoid the false positive septal defects caused by asynchronous wall motion.
Takeaway 2. If the vignette describes a patient with active asthma and expiratory wheezing who cannot walk and needs a pharmacological stress test, avoid all adenosine-based vasodilators. Choose a dobutamine stress test to avoid triggering catastrophic receptor-mediated bronchospasm.
Takeaway 3. If you are evaluating a patient with acute unexplained chest pain in the emergency department, who is deemed intermediate risk, has a completely normal ECG and negative serial cardiac troponins, think coronary CT angiography or CCTA as the next best step to safely, rapidly, and non-invasively rule out an acute coronary syndrome and send them home.
Takeaway 4. If you are watching the monitor during an exercise stress test and you see the patient suddenly develop exertional hypotension, meaning their systolic blood pressure actually drops by 10 points or more instead of rising as they run on the treadmill, think severe, significant multivessel or left main obstructive disease causing global pump failure. Stop the test immediately before they collapse.
Takeaway 5. If the vignette presents a patient with a completely normal baseline ECG and they are physically capable of walking on a treadmill without limitation, do not overthink it. Do not order expensive imaging. The answer is almost always a standard basic exercise ECG. Keep it simple, cost-effective, and safe.
We have covered an immense amount of clinical and physiological ground today. As we wrap up this deep dive, what would you say is the single most important overarching board concept from everything we've discussed?
If you remember absolutely nothing else from this hour, remember this fundamental framework. Your decision tree for ordering any cardiac test must always begin with 2 initial branches. First, assess the patient's baseline ECG. Second, assess their physical ability to exercise. Every complex algorithm, every societal guideline, and every ABIM board question flows downstream from those 2 fundamental data points. And always remember the profound truth that a patient's physical exercise capacity is the ultimate prognostic indicator. Seeing a patient walk 3 stages of a Bruce protocol tells you more about their physiological resilience and their long-term survival than almost any static image ever could.
That is the perfect summary to tie it all together. Before we sign off, I want to leave you with a final provocative thought to mull over, something that points to the rapidly approaching future of cardiology that will undoubtedly be on your exams in the coming years. We touched very briefly on the concept of genetic testing in the source material, specifically regarding cardiomyopathies. Genetic testing isn't just a niche academic field anymore. It is fundamentally altering the logistics of how we practice medicine.
It really is.
Imagine you diagnose a young 30-year-old patient with hypertrophic cardiomyopathy or long QT syndrome. You send their blood for a genetic panel, and you successfully identify the specific pathogenic variant, the exact mutation responsible for their disease. That discovery doesn't just change the treatment plan for the single patient sitting in the exam room in front of you. It sets off a massive ethical and clinical chain reaction called cascade screening. You are now obligated to initiate the screening of their parents, all of their siblings, and eventually their children for that exact same genetic variant.
It expands the scope completely.
Exactly. A single diagnostic blood test in one individual can dictate the lifelong screening protocols, the lifestyle restrictions, and potentially the implementation of life-saving interventions like prophylactic implantable cardioverter defibrillators for an entire family tree extending across multiple generations. We are no longer just treating isolated individuals in a vacuum. We are actively treating entire genetic lineages. It is a profound, immense responsibility that changes the definition of who the patient actually is.
It truly is a paradigm shift. The intersection of genetics, targeted therapies, and cardiology is going to be the dominant frontier of the next decade of internal medicine. It is something every resident needs to be prepared for.
And with that, we want to thank you so much for joining us on Rounds today. We sincerely hope this deep dive has clarified the intense complexities of cardiac diagnostic testing and given you the physiological understanding and the practical tools you need to completely crush this section of the ABIM exam.
Best of luck with your studying and your preparation. Trust your clinical reasoning, rely on the core physiological principles we discussed rather than just memorizing flowcharts, and you will do exceptionally well on test day.
Please remember to subscribe to Evidence at the Bedside Board Review Edition and share this with your colleagues who are preparing for the boards. Keep studying hard, keep caring for your patients with excellence, and we will see you on the next deep dive.